Hi, I'm Amber. I'm a registered dietitian nutritionist, and this is part two of the Nutrition Assessment Lecture Series. And in this video, we are going to be covering the ABCD framework of nutrition assessment. So the objectives for this video, by the end of this video, students should be able to describe the ABCD framework and its purpose, identify and interpret common anthropometric measurements, list key biochemical markers, explain what these values indicate about nutrient status, disease risk, and organ function, collect relevant medical history, and describe common dietary assessment methods. So just a quick recap. The first video addressed what is nutrition assessment. It's the first step of the nutrition care process. It is a systematic way that we collect, classify, and interpret data to identify nutrition-related problems, and it helps identify nutrient deficiencies, understand disease risk, and influence disease progression and patient outcome. For more information, please refer to that first video. Okay, so when we look at the data that is collected in the nutrition assessment, we are referring to the ABCD framework, which provides a very comprehensive picture of the nutritional status of our patients. So the first thing, the A stands for anthropometric, where we're gathering information like height and weight, waist circumference, waist to hip ratio, and so on. B stands for biochemical. We've referred to this as lab work or blood work, which include things like blood sugar levels, cholesterol levels, blood pressure, and so on. Third, we're looking at the clinical data, which entails a nutrition-focused physical exam, as well as gathering information about the patient's medical history. Fourth, we're looking at the dietary information, so either providing and interpreting the 24-hour food recall or food frequency questionnaire or food log. So the first thing we're going to spend some time discussing would be the anthropometric data. And here we're looking at the measurements such as height, weight, BMI, waist circumference, skin fold measurements, mid-arm circumference, which is mainly done in infants and young children. But today's spotlight in this video, we're going to be discussing BMI, waist circumference, and waist to hip ratio. For children, we also have growth charts and percentiles and discuss things like Z-scores. So looking at the BMI or body mass index is a calculated measure of body weight relative to height. And these are the classifications or the categories of BMI. If it's under 18.5 kilogram per meter squared, that's categorized as underweight. Healthy or normal weight is a BMI between 18.5 to 24.9. Overweight is classified as having a BMI of 25 to 29.9, and then obesity is 30 or greater. And here we can acknowledge three classes of obesity, being class 1, 2, or 3, class 3 obesity being severe obesity with a BMI greater than 40, right? So you may find that online there are quite a number of BMI calculators. It's very easy now to go in and calculate the BMI. You may also find BMI charts like this one. So if you want to identify whether or not someone, where would their BMI fall, you are going to do, for instance, if you're saying someone is 5'5" in height, we go across to whatever their weight may be, maybe 68 kilograms, and then we see it falls in this yellow area. Yellow mean overweight. So that's an easy way that we can read a chart like this to identify someone's BMI, calculated by hand or use one of those online calculators. The thing with the BMI, though, there are several challenges with relying solely on a BMI. The BMI does not distinguish with body composition, so you can't tell the difference between muscle and fat. So you may find at times that someone has a higher BMI, but they may be an athlete who has a higher than usual muscle mass. Okay, so we need to be able to read and interpret and understand a BMI within the context of other things. There are some settings where some persons may have fluid retention or edema, whether it's because they're hospitalized patients or they have some conditions such as heart disease or heart failure, kidney disease, and so on that cause them to retain fluid. And therefore, their body weight will not be a true reflection of their fat because BMI is attempting to understand adiposity and excess body fat. And so their body weight at that time is not a true reflection of their body fat. And therefore, the BMI would also be inaccurate. We want to understand cultural perceptions of body size. There are some cultures where having a larger body size is seen as preferable, some cultures where having a smaller body size will be seen as preferable. Moving into the space of being a dietitian nutritionist, you are going to encounter persons of different cultural belief systems. And so you want to understand what is the cultural context of BMI in that ethnic group. Okay. And is there, how is that belief system having an impact on the BMI, general BMI of that patient or community? And then we also want to have one of the challenges with the BMI. Our medical system is based on the BMI. And what we find is that there are issues of discrimination and sometimes a lack of medically tailored treatment options because the prescription would be you just need to lose weight and your blood pressure will come down. You just need to lose weight and your blood sugar would improve. Um, and sometimes there's a missed opportunity to really educate the patient because weight has taken the center stage, and weight loss is put off as this cure all, which it is not, right? So, yes, even if someone needs to lose weight because of their BMI, we also still need to use the opportunity to educate them and get them to understand the importance of this is why we need you to make certain changes versus you just need to lose weight and that's the bottom line. Okay, so the BMI, it's used across the spectrum, but we need to understand how to interpret it in the context of several other scenarios or situations. Now we're going to look at the waist circumference. So the waist circumference, very straightforward, is a measurement that indicates the amount of fat that is stored, or we call that visceral fat that's stored in the abdomen. So it's normal to have some amount of subcutaneous fat, that's fat under the skin. But this visceral fat, it's also normal to have a certain amount because it serves as a cushioning and a protective mechanism, temperature regulation within the abdominal area, which is where the organs or most of our organs are located. So it serves a function, but too much becomes an issue. And so waist circumference is an important measurement. And it's so important that it actually can be used as an independent indicator of heart disease risk. So, like BMI cannot be used as an independent indicator because it doesn't give enough of a picture, right? It can't tell us is it muscle, is it extra fat, is it fluid? It can't help with that. But the waist circumference can be used as an independent indicator of heart disease risk because that visceral fat is linked to high cholesterol, high blood pressure, and type 2 diabetes. Okay, so what we're looking for is there's an increased risk, particularly in high risk, if the waist circumference is over 35 inches in women and over 40 inches in men. So the goal here is to have those waist circumference measures under these um these markers or these cutoff points. Okay. Um so under 35 inches in women would be the ideal goal, and under 40 inches in men would be the ideal goal for waist circumference. So when it comes to measuring the waist circumference, this is just a simple graphic, but it's a matter of you want to stand up straight, exhale, okay? Wrap the tape measure just above your hip bones. Now, there is note to mention that there are two different ways in terms of the WHO has a criteria, the CDC has a criteria in terms of exactly where the waist falls and how do you measure it. One of the measurements is going to be above, just above the umbilical or the umbilus or the belly button. Another one is if you bend at and you feel for the base of your rib cage, then you take the measurement at that point as well. So just very slightly different, but at the end of the day, the goals remain the same. Once we have gotten that waist circumference, we also want to get a hip circumference, and then we use what is called the waist to hip ratio. And that's a measurement that compares the circumference of your waist to that of your hips. And it can help us to assess body fat distribution. So, just like the BMI attempts to give us a story about body fat, and if there's an issue of excess body fat, the waist to hip ratio can let us know where is this fat stored? And is it stored in a way that increases the risk of heart disease or certain chronic conditions or decreases the risk? Right? So this is where we talk about having a pear shape or an apple shaped body. Pear shape meaning fat is stored mainly in the hip area, and apple shape meaning fat is stored more in the abdominal area, and this is a higher storage of visceral fat. So the cutoff that we're looking at here, we want to have in women a waist to hip ratio that is zero point 0.8 or less, and in men zero point 0.9 or less. Okay, and this is what I'm talking about, that apple shape or pear shape. So the apple shape means more of the fat is being stored above the waist, and that's more visceral fat that we're seeing. And this is linked to a higher risk of weight related health problems or chronic diseases. As it relates to the pear shape, we see that more of the fat is being stored below the waist. There's less visceral fat, and this is linked to a lower risk of weight related health problems. Okay, so what we're going to be doing throughout this video, we'll have a case vignette where we are bit by bit, piece by piece, having a case study analysis. Okay, and here we're going to be looking at the anthropometric side of things. So, our patient is Maria. She's a 52-year-old female who was recently diagnosed with type 2 diabetes, and she has reported feeling more tired than usual and occasionally dizzy. So, her anthropometric data, she is 160 centimeters or 5'3", 5 feet 3 inches. She weighs 78 kilograms. Her BMI is 30.5, so class 1 obesity, and her waist circumference is 96 centimeters. So, my question for you, and you can pause the video at this point, what do Maria's BMI and waist circumference indicate about her health risks? So, looking at her BMI, right, being in that class 1 obesity range, and her waist circumference being above the cutoff for females, which equates to about 88 centimeters, it lets us know that Maria has an increased risk of developing type 2 diabetes. Well, she was recently diagnosed with type 2 diabetes, so we can see the connection there. Why? Because that increases, these markers increase that risk. Should also have an increased risk of developing heart disease. Okay, so her BMI and waist circumference can indicate that to us. Okay, so let's jump into the biochemical data. So looking at that ABCD framework, this is number 2. We covered anthropometric data, biochemical data. So here we are looking at lab data, right? Glucose levels, lipid profiles or triglyceride or cholesterol levels, hemoglobin, albumin, electrolytes, and so on. And this biochemical data, these reflect the nutritional status of the patient. It can also indicate organ function, and it can indicate the disease risk or management. How well are they managing their condition, or are they at an increased risk of developing certain chronic conditions as a result of their biochemical data? Now, we need to interpret these bits of information appropriately because these labs can be influenced by hydration, right? Is the person dehydrated or in some cases overhydrated? Are they stressed? Whether that's psychological stress or also maybe had a recent period of infection that brings about a physiological stress response in the body. And certain medications can also cause labs to look a little um, inaccurate. So we always want that the lab should be interpreted in context with other data. Let's talk about blood sugar. One of the things you're definitely going to be speaking about a lot as a dietitian nutritionist would be blood sugar management. Whether or not your client or your patient has diabetes per se, there are a number of conditions, including things like PCOS, polycystic ovarian syndrome, endometriosis, insulin resistance, a number of conditions that warrant having conversations around blood sugar. So, blood sugar tests reveal directly the level of sugar or glucose in the bloodstream. And what we look at is we want a fasting blood glucose that is under 100 milligrams per deciliter. Before meals, it can even go up to 130. After meal to our postprandial blood sugar, ideally should be under 180 if someone already has diabetes, or under 140 if they do not. And the HbA1c or glycated hemoglobin, these markers suggest under 5.7 is normal, 5.7 to 6.4% indicates prediabetes, and 6.5% or more can indicate diabetes. Right? And this is a graph from the American Diabetes Association, just showing some correlation between an HbA1c percentage to a finger prick blood sugar level, or in some cases, persons even read it in millimoles. So you have a concept of what these things equate to. For instance, a 6% HbA1c correlates an average blood sugar of 126 milligrams. Okay, and that is the pre-diabetes range. And that can equate to a 7 millimole per liter blood sugar levels as well, depending on the units in which the blood sugar monitor is in. Just a quick note here as well on the A1C. So it's referred to as the glycated hemoglobin, and once the units of sugar in the blood, they tend to, in simple terms, attach themselves to the hemoglobin. And this is one of the more accurate ways to check blood sugar levels, because the finger prick, like checking the 2 hour after meals or fasting blood glucose levels, those change every day. Um, those rise and fall daily. Okay, and so you can check it today and it's okay, check it tomorrow, it's high. The A1C, however, because it's glycated hemoglobin, hemoglobin has an average, or red blood cells have an average lifespan of 90 days. So the A1C is a reflection of that blood sugar management or average blood sugar levels for the past 90 days, right? So even if someone has an A1C done now, the standard recommendation is repeat it in 3 months, because we need to see that 3 month average of what's happening there. Okay, so sometimes you may come upon a patient who's like, well, I check my blood sugar, and every time I check it in the morning, it's good, but then the A1C was high. Right. Maybe the morning blood sugar is good and the evening sugars are high, and the average is therefore higher, and the A1C can reflect that. Okay, so that's a quick note on the HbA1c. As it relates to things like blood pressure, this is another very common thing that you're going to be discussing with patients, because we have high rates of blood sugar, blood pressure, hypertension in the Caribbean, right? So the blood pressure reading is a measurement of the pressure force inside the arteries. And there are two numbers that we look at. So the top number is the systolic blood pressure, and that's a pressure in your blood when it's pushing against the artery walls when the heart beats. So when you get that heartbeat, that's a systolic. That's why it's usually higher. It's an active contraction of the heart muscle. The diastolic blood pressure, or that bottom number, the pressure in your blood is pushing against your artery walls while the heart muscle rests between beats. So the systolic, or the top number, is an active contraction of the heart muscle, and the diastolic is while the heart muscle is in a semi-relaxed state and the blood is filling back up with blood. The heart is filling back up with blood, sorry. And so you get these two. So the diastolic is expected to be a lower number, because that is a sort of rested state for the heart at that time. But when it comes to understanding and interpreting blood pressure categories, we're looking at a normal blood pressure being top being less than 120 and the bottom number being less than 80. Now, elevated blood pressure ranges anywhere between 120 to 129 systolic and less than 80 diastolic. And this is important to note, because sometimes somebody may consistently have a diastolic that's less than 80, but the systolic is higher, or it's ranging is in a certain range, and that alone can cause the staging of hypertension to come into effect. So stage 1 hypertension is where the systolic ranges between 130 to 139, or 80 to 89 diastolic. So even if you have a 120 systolic, but the diastolic is 89, you can still get diagnosed with stage 1 hypertension. It's either or at this point. Same thing we see as it moves up. So stage 2 hypertension, a 140 or higher systolic, or 90 or higher diastolic. And there's some people who have both. Okay, they're going to have a high systolic and a high diastolic. Severe hypertension, higher than 180 systolic and or higher than 120 diastolic. And then a hypertensive emergency would be the same numbers as the severe hypertension, but we're looking also for certain symptoms that may be manifesting at that time. Okay, so let's go back to our patient, Maria. So Maria, as we've identified, was recently diagnosed with type 2 diabetes. She's 52 years old, and she has reported feeling more tired than usual and having occasional dizziness. So the biochemical data that in this sample case has identified her fasting blood glucose is 160, which is elevated because we identified it should be under 100 or and before meal up to 130, right? So this is high. Her A1C is 7.8%, which is also high, right? Under 5.7% is considered normal. That 5.7 to 6.4% is considered pre-diabetes, and 6.5% or higher would be considered diabetes. Her hemoglobin is 11, which is slightly low for women. It should range should be at least 12, 12 to 15. Men it's usually 13 to 17 or 14 to 17, depending on the lab. And then her serum ferritin or iron is 12, which is also low. So the question here, and again, pause and reflect on it. What do her glucose and HbA1c levels suggest about her diabetes control? Also, what might the low hemoglobin and ferritin levels indicate? So you want to pause, reflect and answer, and then we would also be doing an entire case summary at the end of this video. Okay. Let's look at some clinical data. So the clinical data is going to include a nutrition-focused physical exam, and this will be covered in a subsequent video. But it entails a systematic way of physically analyzing the body, the patient's body, looking at the hair, skin, nails, eyes, or oral cavity, um, to make some judgments around or an assessment around um, are they at risk for any nutrient deficiencies? Is there fluid retention? What's happening physically? We also want to gather medical history, medication use, and identify signs of nutrient deficiencies. And then gather information about signs and symptoms, right? Such as if the person has pallor, there's a possible iron deficiency. So the clinical nutrition focused physical exam, this is something that's specific to registered dietitian nutritionists, and it entails some training and getting really competent with completing a nutrition focused physical exam, as well as understanding how to make an assessment and analysis or judgment of giving certain things a category, because it is also important towards identifying or diagnosing malnutrition, right? It's very important for that. It involves assessing physical signs of malnutrition, nutrient deficiencies, and evaluating overall health. And it would include things such as grip strength, okay, signs of fluid, which is grip strength is particularly important for the older population because it can indicate some aspects of their muscle health. We look for signs of fluid retention or dehydration. You want to assess muscle and fat stores in the face and around the body. We want to look at skin, hair, and nail health, and mouth and eye evaluations as well. The mouth evaluation, you want to get a concept of do they have dentures, are they missing teeth, because this can impact the nutrition. And eye evaluation, there's some nutrients, vitamin K or vitamin A, the deficiencies of those can show up as certain signs and symptoms on the eyes. Right. So looking at clinical data for Maria, her physical exam showed that she has pale conjunctiva, which would be that in her eyes, if you were to pull the base of the eyelid down and you look in that area, it is pale. She has brittle nails. Okay, so it's telling us something. She has hypertension and she's on medication for that. So while the initial thing is telling us Maria's recently diagnosed with type 2 diabetes, the further investigation also allowed us to recognize she has hypertension as well, high blood pressure, and she's taking medication for it. Has not had any recent hospitalizations, which is always important to know whether or not the patient had one, right? Sometimes they may have had a hypertensive emergency, a number of complicated things are happening, and they could have been hospitalized. And she complains of fatigue and occasional lightheadedness. So the question here is pause and answer. What clinical signs support the possibility of iron deficiency in Maria? What would you look at as a clinical data to say, well, this lets us know that she can have iron deficiency? All right. And last up, we're looking at dietary data. So this is the D in the ABCD framework. And the methods of collecting dietary data include a 24-hour recall, food frequency questionnaire, food diary, and overall diet history. Now, the thing with these, I'm going to go into them, but Keep in mind that sometimes there are multiple sources of errors, underreporting, overreporting, whether the person can remember or not, portion size estimation, right? You may even stop to think, what did I eat yesterday? I can't remember. Much less asking an older person, or depending on the context of the environment in which you're asking them as well. So we can acknowledge that there may be some sources of error when it comes to gathering dietary data. So the first thing we're going to look at is a 24-hour recall, and it's a structured interview that is intended to capture everything that the patient ate and drank in the past 24 hours. And it can provide quantitative information, right? So the amounts of things. It can help to give an estimate of mean food intake and nutrients, and it's typically short and easy to complete. However, it can be inaccurate, especially if an atypical day was used, or depending on the assessor's competence. So, how well do you know to pry and ask the relevant questions can determine how detailed and valuable a 24-hour recall is. Also, if the person said, well, yesterday really I wasn't well, I didn't eat as usual, I was busy, it's not a good reflection of my day-to-day eating. So sometimes if an atypical day is used, it may not give an accurate picture of that person's dietary habits. The food frequency questionnaire, right, can give us a bit more information because it's an assessment tool that is going to evaluate that patient's food and beverage intake over a period of time, whether that's a period of a month, 6 months, or a year. And what it entails, it has a finite list of foods and beverages. So they're detailed, it's very typically very detailed, and they're going to be portion sizes for each food or food group. So you may have a portion size for pumpkin, or you may just have a portion size for non-starchy vegetables, right? And typically it's inexpensive. Sometimes it can be self-administered, so you're able to give it to the patient to fill depending on their literacy level. Are they able to read? Can they completely fill this form or not? And it can capture their usual intake. However, with something like this, again, this is where the memory can become really tricky because they may end up under or over reporting the intake over a period of time, especially if it's a 1 year food frequency questionnaire. You may just guesstimate instead of provide an accurate reflection of what they're really consuming over that period. And next up, we're looking at a food record, also called a food diary or food log. And this can be a more detailed account of all the food and beverages consumed over a specific period. On average, you may ask your patient to fill a 3-day food record. If you want more detailed information, you may ask them to fill a 7-day food record. And this can help you to identify eating habits and patterns and their day to day because you get to see how they are eating in relation to um, their work schedule or just work life balance. You also want to capture in the weeks or weekday versus a weekend. How different is it on a weekend depending on the person's job, the nature of their job? You may see different dietary patterns in the weekday versus the weekend, and it can help you to capture detailed intake when done thoroughly. So you want to make sure that there are clear instructions for that patient on how they should fill this food record. But there's a con as well, depending on the literacy of the patient. Can they fill it on their own, right? That can be a challenge for some patients, and that's a reality that we have to look at. And for some persons, it may feel tedious. They may provide an incomplete food record as well, depending on certain challenges that they may be facing at the time. So this one can be very beneficial in providing some bits of information if it is thoroughly done. All right, so let's look at the dietary information for Miss Maria. So our 24-hour recall showed that at breakfast, she had 2 slices of white bread with butter, tea, and tea with sugar. Lunchtime, she ate fried chicken with white rice and a small side of coleslaw. Snack time, soft drink and chips. Dinner, roti with curry goat, right? And then she would have drunk 2 to 3 sugar sweetened beverages daily, little fruit or vegetable intake. And she also reports skipping meals sometimes if she doesn't feel hungry. So the question here for you, and pause again as you need to. What patterns in her diet may be contributing to her health concerns? So her health concerns, she's hypertensive on medication. She was recently diagnosed with type 2 diabetes. And she's reporting that she's feeling more tired than usual and occasional dizziness. And we are suspecting, does she have iron deficiency? So when we look at this dietary recall, right, we're just providing decent information. What can you say may be contributing to her health concerns? And let's look at the entire wrap up of this. So when we look at Maria's case, considering all of the data, some of the key nutrition concerns. So when we looked at her biochemical data, we saw her fasting blood sugar was high. We also saw that her hemoglobin and iron levels were low. When we look at the clinical signs and symptoms, we saw some signs of potential iron deficiency when we looked at the brittle nails as well as her pale conjunctiva, right? Can be indicative of that. Her fatigue as well as dizziness, because with iron deficiency, anemia, and having a lower hemoglobin, those are responsible for carrying oxygen throughout the blood. Oxygen is going to make you having low oxygen levels, sorry, can make you feel fatigued, can also give that dizzy feeling because you're not getting enough oxygen to the brain at certain points in time, right? So we are suspecting an iron deficiency. So when we look at everything all together, we're seeing that assessment. So we're gathering all of this assessment data for Maria, right? We're seeing she has poor glycemic control. And that's because of her high HbA1c, 7.8%, as well as her high fasting blood sugar is 160. And it is linked to her dietary intake and obesity. Dietary intake, we saw that she had insufficient or sometimes rare intake of fruit and vegetables, and she was consuming a lot of sugary beverages. She had the white bread and the white rice. We didn't have a clear concept of all of her portion sizes. So it was just fried chicken and white rice. We didn't get the amounts for those. So sometimes that can also, you know, we'll need to pry a little bit more to get the amount. Okay, but we're seeing the link with her dietary intake. We also see that she has obesity, class 1 obesity with a BMI of 30.5. So we're also looking at iron deficiency anemia related to an inadequate intake and or absorption. So again, we could look at her diet and determine is she eating sufficient iron-rich foods, which would entail some dark green leafy vegetables, certain animal-based proteins you can consider, or plant-based iron-rich foods as well. And if for some reason we came to the conclusion that she was, then she would need to be investigated further from a medical perspective to determine maybe there's an absorption issue there. We are also looking at a low fruit and vegetable intake that can contribute to nutrient deficiencies and a poor overall diet quality. So these are some of the things that stand out when we look at the assessment on Maria. Okay, poor glycemic control and deficiency, and low fruit and vegetable intake. The takeaway here is that there's no single data source that can tell the full story. We need to integrate the anthropometric, the biochemical, the clinical, and the dietary information to identify meaningful nutrition problems. If we just look at one, we really miss the opportunity to provide personalized nutrition care. All right. So that's it for the ABCD framework of nutrition assessment. And up next, we're going to be looking at conducting a nutrition assessment step by step and how you, as a dietitian nutritionist, can complete a nutrition assessment.